Sorry about that. Welcome to today's program, Modeling Chicago for the COVID-19 Pandemic. This is our first program of 2021, but we've got a busy schedule ahead of us. So please check out our website, look at the events page to see everything that's coming up. In this program, we're partnering with Argonne National Laboratory, who happen to be celebrating their 75th anniversary this year. The Argonne National Laboratory is a Department of Energy-funded multidisciplinary research center with over 8,000 researchers who are dedicated to answering the biggest questions facing humanity. And if you're new to our programming, C2ST is a non-for-profit organization who's dedicated to furthering science and technology initiatives and understanding within the city of Chicago. If you're interested in donating to support our programming, please go to c2st.org and click Give Now. If you like our programs and you want to learn more about them, we encourage you to join our mailing list from our website too. During today's program, if you have any questions from our speaker, please visit c2st.cnf.io. You can type that right into your browser and you can ask questions of our speaker for our Q&A session towards the end of the program. We also have staff who are going to be on both Facebook and YouTube, and they can collect your questions and post them for you. Now, to get into today's programming, we have our speaker today, Dr. Charles Chick McCall from Argonne National Laboratory. Makel. Dr. Makel is a distinguished fellow and senior systems engineer and group leader for social and behavioral systems at Argonne National Lab. Dr. Makel applies computational modeling and simulation tools to complex systems in order to solve problems in a variety of fields, including energy, national security, and as we're going to learn today, public health. Dr. Makel, thank you for joining us today. We're really excited to hear about CityCOVID and learn a little bit more about your work.
Thank you, Alex. I have a presentation to share and a few PowerPoint slides, and let's see if we can get that up on the screen. Did that come up?
Yes.
Okay, great. Thank you. Okay. Hello, everybody. Good evening. My name is Dr. Chick Makel from Argonne National Laboratory, and I'm pleased to talk to you today about modeling Chicago for the COVID-19 pandemic and share some of my experiences on the front lines of epidemiological modeling to support decision makers in Chicago and in the state of Illinois. Just a funding kind of acknowledgement. This research is supported by the Department of Energy, Office of Science through the National Virtual Biotechnology Laboratory, which is a consortium of DOE national laboratories funded by the Coronavirus CARES Act. So in terms of what I'd like to talk about, as the COVID-19 pandemic unfolded, the modeling community, and by that I mean people who basically use computers and mathematical models to of essentially the epidemic and how it will unfold, mounted an impressive response to support decision makers with forecasts of how COVID-19 and the SARS-CoV-2 virus could progress. At Argonne, we have developed a model called CityCOVID, which is a large-scale agent-based model, and applied it to predict the spread of COVID-19 in Chicago. We have been doing this work since last March, when the pandemic really first came to Chicago and various actions were done to in response to it, including the initial shutdown, etc. Agent-based modeling focuses on modeling individuals in an entire population at the individual level. CityCOVID, the model, represents the process of how COVID-19 spreads for understanding the effectiveness of interventions in Chicago. We are providing the mayor's office with projections for what-if scenarios. We are briefing Cook County public health officials as well. And we're sharing results with the Illinois Governor's Modeling Task Force, of which Argonne is a member, along with research groups from Northwestern, from the University of Chicago, and the University of Illinois at Urbana-Champaign. In the CityCOVID model, we represent or model the entire population of 2.7 million people in Chicago as they move through their daily routines, hour by hour, between and among the entire 1.2 million locations where people are located. My story begins in terms of the epidemic modeling with the Ebola outbreak in West Africa that began in 2014. At the time, I was part of two federal task forces, one for Department of Energy, the other one for BARDA, which is part of Health and Human Services, that were trying to understand the course of the outbreak and what could be done to stop it. Although many modeling groups at the time were focusing their efforts on West Africa, my particular focus was on understanding what could happen if Ebola came to the United States. From this engagement, I will always remember a couple of things that said by Dr. Richard Hatcher, Chief Medical Officer at the time of BARDA. He said, decision makers at the highest levels of government are asking, and they are asking for the first time, what do the modelers say about the course of the outbreak? That situation spawned the research that eventually has led to the CityCOVID model. And when Ebola was finally winding down in January of 2015 and the task forces were being disbanded, people went back to their daily jobs and drifted out of their positions. The often repeated phrase, however, was, it's not a matter of if, it's a matter of when. And this spurred the modeling efforts continuing forward from that day onward and kept modeling at the forefront of the tools that could be used in anticipation of the next pandemic. And we have been doing this work ever since that time here at Argonne. Just a recap of COVID-19 in the US and Illinois. Last March, the governor issued a disaster proclamation restricting visitors to nursing homes, followed by closing of bars and restaurants for on-site consumption. Schools moved to remote learning. In March 21st, the governor issued a stay-at-home order, and in May announced the Restore Illinois plan, which allows us to move in phases back to normal society. The state did begin to reopen, as you recall, in May, and we've had various degrees of restriction and orders since then that have advanced according to the metrics for the various regions in Illinois. Here's a map of Illinois, and these are the 11 emergency medical service regions that Illinois is roughly divided into. And these have been adjusted somewhat as to their current regionalization with respect to how well different counties, so to speak, are doing in the various regions in terms of restrictions and reopenings and things like that. But kind of a regional approach has been taken. As you know, we have 5 phases for each Illinois health region to move through. Currently, we are in phase 4 for many of the regions, and we hope to go to phase 5. As you know, sometimes if the metrics are going in the wrong direction, so to speak, then there could be some additional closures. We might kind of go backwards in these phases. But from the beginning of the new coronavirus pandemic, Illinois' response has been guided by data, science, and public health experts. And that's why I'm talking to you today, because we're part of that group that does modeling work and essentially make sense of all the data that's coming in to provide forecasts of what the future could hold, and in particular, what the effects of what we call non-pharmaceutical interventions could be on the part of public health officials, as well as how people may respond in their own behaviors. CityCOVID, the model, provides data for key questions by decision makers. There's many questions that are coming up. These are changing and weekly. such as what is the importance of individual protective behaviors, such as wearing masks or 6-foot distancing? How do behaviors of different age groups affect transmission and hospitalization? What is the importance of activity and mobility and contacts versus individual behaviors in affecting transmission between people and individuals? How do children and schools affect the spread of COVID-19? What are the effects of the timing of imposing and lifting various interventions? And what we do with the model is we can test these interventions before they're actually implemented. And there's many other questions that we're focusing on and have been, as I said, modifying during the course of the pandemic. So the question is, well, there's all these questions. How do you answer these questions? And how do you bring science into the whole process? So really the answer is what we call epidemiological modeling. You may have heard about, let's say, the IHME model. We see Chris Murray reporting, regularly on national nightly TV about projections for the whole nation and the country as a whole. There's various types of models. Some are statistical, some are compartmental, as we call them. Some are network models, some are mechanistic models, which really get into the details of what people do to have contact and the transmission possibilities. CityCOVID, the model we built, is very mechanistic and it's very detailed. It's an extremely detailed model. And this requires the use of the supercomputers here at Argonne, which I'll mention later in the process. Yes. Yes, hi. That was a recorded session for that slide. So glad I could interrupt myself and jump in there. But in any case, yes. So the question, another part of our activity is the question: where is the science? So the point I'd like to make is all of the science that we hear about, and we hear about it every day. New things are being discovered about the transmissibility of the virus. Even about the effects of the vaccinations, and many other individual single parameters, many of which each individual parameter scientifically is a whole research paper in itself. So with the CityCOVID model, we're able to take each piece of science, each piece of data, and incorporate that into the larger framework of what it means for the spread of COVID-19, in particular in the Chicago area. And this slide's an example of the many papers on the right side, scientific publications on various aspects of COVID-19. And the extraction of that data goes into the model and the diagram you just saw about how it affects the flow and the transmission, whether it's by age or other factors. From the entire end-to-end process, from a person becoming exposed at some point in time, going through the various stages of the disease, possibly requiring hospitalization, possibly being asymptomatic, possibly being symptomatic but not severe enough to require hospitalization, and then through the hospitalization process from entering the hospital to potentially going into the intensive care, and from there potentially requiring even ventilators, and ultimately be recovered or possibly resulting, in death. So all of these possibilities are included within the model. This diagram shows you kind of the basic idea of agent-based modeling. So for every person or in Chicago, we have a representation of them in the computer. And we take data like census data, demographic data, and populate the model with these data to represent the people in the model. I want to go back to that slide. But we don't actually have actual data on actual people. As I said, it's census data published from open data sources, and we simply create, let's say, these attributes that match the larger functions of the data across the population. So if we added up the individual characteristics of the population, they would match the data at the census level, but there's no single agent or data that actually represents the actual, all the attributes of a single person. Anyway, we have 2.7 million agents who could go to the 1.2 million places in Chicago City proper, and we represent their movement, their activities they do on an hour-by-hour basis, day by day, week by week, month by month, over a course of a year. Each agent also has behaviors. They engage in activities, they respond to potential infections, as well as public health messaging. The basic idea of modeling disease transmission is this. We take persons as agents, we take the places, and then we add activity schedules people will have. They may be at home, they may go to school, they may go to work, etc. during the course of their day. When they go to places, as we simulate them in the model, they actually have contact with each other in the model. This contact allows the possibility of disease transmission. So in the model, if there's an infected individual, there's a probability that they could infect other agents that they're also located with at exactly the same place. Now, we have a lot of places represented. The main place types for which that are relevant to COVID-19, households, workplaces, restaurants, recreation, grocery stores, schools, etc. And we also have individual statistics on ages of our agents in the model by age groups, 10 to 20, 20 to 30, etc. Because people are having different outcomes relative to their age, and they have different possibilities for how they might behave, so to speak, or engage in social distancing, or how they might get vaccinated, for example. So as I said, we have the demographic characteristics of people living in Chicago that we include in the model. Some critical questions have to do with essential workers and vulnerable populations, and how the whole nature of the pandemic is potentially affecting them. So this is an area we spent a lot of time collecting data on, including the homeless populations. Early on, there were some questions about what the role of the homeless populations are in, transmitting the disease, and also how vulnerable they were to it. As I mentioned, we represent all the places in Chicago. This particular set of data is for the extended version of the new model version we're working on for not only Chicago, but the entire 7-county area. So we have plans that we're finishing up to actually model the entire region and then eventually expand it to the whole state. But again, this is where we need a lot of computing power, and our supercomputers come in. So the basic idea is we're simulating these agents going through their daily schedules, hour by hour. They go to places, and they engage in activities at the places. Those activities that are at co-located places represent contacts people have. And when there's contacts, there's the possibility for an infected agent infecting another agent. And once that process starts, once an agent gets infected, there's a whole chain of events that can occur as that agent goes through the various other disease stages that I mentioned. I did mention our supercomputing resources here at Argonne that make this all possible. We have a computer called Theta, which is one of the most powerful and largest computers in the world. It's this building right behind me here. We're building a new building to have an even more powerful computer. But even with our powerful computer Theta crunching out all of these numbers in our simulation forecast and also estimating the various model parameters, it could take 50 or 60 hours of clock time to do a single run. So it's very challenging, and we could always benefit greatly from new computing resources that are bigger and faster. The reason is because we need to get information to decision makers much more quickly than we can now. Their questions are coming, the situation is changing as COVID-19 spreads. Many questions now regarding the variant strain. Will that have a big impact? And the answer is probably yes. But we haven't finished those computer runs yet. They're still in the computer cooking, so to speak. Of course, the other questions are vaccinations. What we would like to do is to do some forecasts of how quickly new infections will diminish, hospitalizations will go down, etc. So that's kind of what we're constantly working on. We do use real data, and it comes in daily for Chicago on the number of people that are in hospitals due to COVID-related illness, as well as the number of deaths that continue to mount. We include the daily data into the calibration of the modeling, so we get new estimates of model parameters. This is basically our kind of dashboard that is telling us what the data that's coming in really means with respect to things like transmission. What are the effects of social distancing at reducing transmission, for example? So we can, view these charts that come out of the modeling work, and we can kind of make sense of it all and report our results to decision makers. Anyway, again, supercomputers are essential. So, decision makers, they want to know key things. They want to know hospital admissions. They want to know ICU utilization, because we're often getting close to have, to the limits of what's available for hospital beds, what's available for hospital staffing, what's available for ICU resources, things like that. So we're forecasting out like a month in advance to see whether we're going to get close to what those limits actually are. Decision makers want to know how many new infections are coming. Is it going up or down? Deaths, of course, are important to project. And there's something called R effective, which is stratified by age group. And you may have heard about R effective. It's sometimes called R naught, sometimes called RT. But it's probably the key measure of understanding if, let's say the pandemic is getting worse or getting better. Many things follow from it. Anyway, R effective is the average number of new infections produced by each person who has COVID-19 and is infectious during the course of that person's being infected. So this value changes over time, and a value greater than 1 means every person who gets infected infects more than one person during the course of their infection. And as you can imagine, if every person infected infects more than one other person, then pretty soon you get a greater and greater number of people becoming infected. So essentially, this is the basis for exponential growth of the pandemic. If R effective is less than 1, the epidemic is declining. So eventually, it'll just kind of basically peter out. all other things being equal. So if R effective is about 1, then you're getting a lot of infections, and things just kind of keep going, indefinitely as more and more infections. It's like a machine producing more infections. Anyway, some of the things that we have been running with the model cases are things like the effect of individual behaviors in response to societal reopening. This is a projection we did very early last summer, and we looked at what the effect would be if people did adopt social distancing behaviors. And by social distancing, I mean things that reduce transmission person to person. The primary one is to wear masks. Yes, masks do reduce transmission. Also, the social distancing, 6 foot apart rule, as well as sterilizing surfaces, etc. Anything to do with preventing the spread. In the scenarios that we ran, we see the graph on the left here, it results in less infections. The number of infections declines strictly. The graph on the right here was same simulation, everything being equal, except after the reopening, we assumed people did not adhere to these strict, social protective behaviors. And as you can see on the right, we see the number of infections increasing. So this is very dramatic illustration that social distancing really matters in that one-to-one situation of people interacting in terms of transmitting the virus throughout the entire population. Another thing we looked at was we did analysis of back to school. So as you recall, in September, there were several questions about school reopening. And there were different programs that different school districts had implemented, everything from complete back to school in person reopening to strictly at home schooling to some hybrid programs in between. And so we ran all of these scenarios through our model, which, and basically our findings had to do with that if, and this is a big if schools can implement and somehow enforce very, very good self-protective behaviors, if all the kids wear masks and there's certain distancing that's followed, etc., then we found that school would not be a good source, not be a big source of transmitting the infections. And I think that just based on the fact some schools in Chicago did open up in person, and that we've kind of seen that unfold, and it continues to be a result that we affirm from the model output. As I said, we do age stratified forecasts and things, and we can model different behaviors that different age groups have. During the summer, there was a big question about younger people that, let's say in the 28 to 30-year-olds or even to 40-year-olds, maybe weren't adhering to protective behaviors quite as much because their, outcomes, the chances of them getting severely infected were much lower than for anyone over 50 years old. And the science and the data, really, supports that. So we did various scenarios looking at what the different age groups were in terms of their, let's say, their propensity to, their role, let's say, in the overall spread of the COVID-19 infection. We did, let's say, portray these results to decision makers. By the way, the black curve is kind of the sum total of everything. And you can see, at the end there, for either on the left or the right, it's right around 1.0. These are our effective values of 1.0. So what that means is overall for society that there's just going to be a lot of continuing infections. indefinitely at that point. And just as a follow-up, we've done many other, forecasts and simulations, and we have seen our predictions for our effective value have it to be our effective is still right around 1 or a little less than 1, maybe about 0.85 or something like that. And these kind of projections are in agreement with the other modelers in the Illinois Governor's Modeling Task Force modeling group at this time. However, there's a few challenges. There's two things that are going on now. One, as you probably know, we have the so-called COVID variants. And the variants, whether they're South Africa or from the UK, B117, or from Brazil, and who knows from where else is the next one, these are much more transmissible. So it could be 50 or 60% more transmissible. So what that means is it could be that a person who, with the original strain, let's say, on average infects one person, it could be, being R effective as 1. It could be that suddenly maybe they infect 2 or 3 people, and it averages out to 1.5 perhaps. So this is something we're really worried about, the effect of the variant. And as the variant spreads, as a greater proportion of the COVID that is being transmitted to people, then we can expect the potential for an increase in the number of new infections moving forward. Second point to make, though, is we have the vaccine, we have the vaccinations coming on. And all of our analysis, all of our work suggests highly that the vaccinations will have a big impact on stopping the spread of COVID-19. And so the whole issue about either vaccinations or the disease continuing is to achieve what's called herd immunity. And so various other scientists have estimated that we need to achieve a herd immunity where 80% of the population is either has already had the infection, is therefore immune to further, as far as we know, or has been vaccinated or simply, succumbed to the infection. So between those things happening, this is how we can chart a path, so to speak, to effective herd immunity and to really stop this thing and get back to society to normal as soon as possible. Anyway, that's what I have to say. Thank you for listening. And one of the key outcomes of the work I'm doing is to kind of make it better for next time, for the next pandemic, because it's not a matter of if, it's a matter of when. Thank you very much.
Awesome. Thank you very much for sharing that, Chick. I think it's really illuminating, and I think it's really amazing how detailed and specific the model is able to get and how many different agents you said you're able to capture throughout. We do have a few questions that popped up while you were speaking, so we'll go through those now. The first one cites from another paper found in Science, and it's pretty specific, so I'll do my best to exactly capture what they're asking. Okay. So from another study, they created a model that said to reduce deaths, one should target adults aged over 60, but to reduce the number of infections, one should target adults aged 20 through 49. Which of those two strategies is being followed in Chicago? And is there a prioritization of strategy that your model suggests is optimal?
Well, certainly in the initial vaccinations, the long-term care facilities, as we call them, nursing homes, those were amongst the very first people, as well as healthcare workers, and they were having a lot of contact with people. Those were the initial pool of vaccinations. And the pools are divided, vaccinations 1A, 1B, et cetera. We're moving to 1B now. And 1B includes, like I said, the emergency workers, healthcare workers, long-term care facilities, but also it adds to people over 65 years old. The people that are over 60, the higher age groups, tend to not spread the infection very much. But the measures that are put in place about vaccinations are as much to protect them, to save lives directly. In terms of the other kind of objective, so to speak, in terms of reducing the spread and reducing the infections, then I really can't speak to the point that was raised in the paper, the second point about I think it was the age group, vaccinate age group 20 to 49. It's complicated, okay? I mean, I'm not a public health official and things like that, but I will say that there, in the younger age groups, there is a lot of asymptotic, as we call it, spread without people being symptomatic. So there's a thought that asymptomatic people are spreading the infections and not knowing it, and targeting them in particular would also stop the spread. So that's about the best I can say. I can't give you, I mean, we have not run the model to answer the specific question as to which age group should be, let's say, targeted, that has the most impacts on the spread. However, I would suggest that based on the R effective values that I showed, the R effective values, as I said, for the 20 to 30, 30 to 40 were higher than 1 than for the other age group. So by that logic, it would make sense to, vaccinate them, people in those age groups, to stop the spread. But I can't give you a quantitative answer comparing all the possibilities. It's a good thing to, run the model for. I should say, we run the model. We're running the model 24 hours. In fact, we're almost working 24 hours a day, the staff and everything, just to keep up. And, so these are all great questions, and we hope we can get to them.
Yeah, I think it's always difficult to interpret results, right, when you don't have the paper in front of you. So and that was a few pronged question, but thank you for answering it.
Yeah. Thank you for the question, by the way. I appreciate the question.
Yeah, it was a good one. Someone else is wondering whether the model accounted for different seasonal behaviors, such as people gathering for the holidays or the change in season, people not being able to go outside as much or things like that.
Yes, we did account for seasonal changes. To some extent, the seasonal changes are built into the model in the sense that people have different patterns of going places, depending on the season. And they have different behaviors when, let's say, they go inside relative to social distancing and things. As we know, it seemed, being outside, particularly in the daylight, seemed to be a protective behavior. In well-ventilated outside areas seemed to be protective. But when the fall came and people went more inside, and possibly through other factors we're not even aware of, then that's when the second peak started to occur, throughout, starting in September throughout October. It's kind of a 1-for-1. We don't know if people just kind of relax their protective behaviors. There is something called, COVID fatigue. We just get tired of doing these procedures. But, it's COVID is a relentless, virus. And it doesn't take any time off. We did also, though, we did specific runs of our simulation where we looked at the impact of holiday gatherings, as we call them, around the Thanksgiving week and also around the, Christmas holiday.
Mhm.
And those were basically kind of impulses where there's more contacts that are going on in a model, and there's less strict, social distancing being followed. And we found that there was an impact, yes, of the social gatherings both times, hospitalizations and things that eventually resulted from the relaxations, holiday gatherings, increased like hospitalizations by 10% or so. So there were effects, but the effects were not large enough to cause like a crisis in the healthcare system, which is kind of the bottom line, of course, of the information that public health officials have to be aware of and plan for. The hospitals are such a critical resource that one of the metrics is whether we're 20% under capacity, of the hospitals. And we help forecast that, for the next 30 days or so to kind of give it, red flags, so to speak, of real possibilities.
Yeah, that's a very helpful answer. I think it's really illuminating in the, all the different things that are taken into account to create a model, such as predicting people's behaviors around the holidays, predicting when people are going to have COVID fatigue. I think that's something you hear about a lot is people, they sort of run their course of how much COVID they can handle. And I know we've heard about it since we've been doing programming on COVID.
I do want to make one point about behavior.
Sure.
We don't predict the future. This is not a model of the future. It's more of a forecast, like a weather forecast. There's a certain chance that this can happen. There's a bigger chance, these other events can happen. And when and we cannot predict people's behavior, but what we can do is consider alternate behaviors people may have and run different, as we call, scenarios. So we can run scenarios where people relax their protective behavior, do all those forecasts, and then we can run scenarios where people adhere to strict protective behaviors and compare the differences and report that kind of information. And then, it's up to a judgment or depending on worst case, best case scenario decision making, as to how to interpret those results and what it means for taking action, by the governor or the mayor. That's not our job as scientists. We're simply providing, scientifically based, data-driven, reproducible information to the decision makers.
Thank you. Yeah, I think that is a really important point to know that no one can quite predict the future, but the more data you can capture and the more you can provide people who are making decisions, I think the better, hopefully the better decisions that are made, right, is the ultimate goal.
And I will say the decision makers we work with, they really do appreciate this information, both at the governor level, at the mayor level, as well as the county. Cook County in particular, we're tied to a little bit. So, yeah.
Yeah, it's good to see that joint effort. So I do want to be mindful of people's time, and I think we said the program would be about 45 minutes, so we'll try to keep it at 45 minutes. Chick, thank you so much for your time, for your expertise, for sharing about the CityCOVID model and the work that you've done to, support the health of everyone in Chicago and the surrounding areas. And, hopefully everything that you're learning from helping model this pandemic can make sure the next one is not quite so stressful for all of us and we all end up better. So thank you for your time.
Thank you very much.
Yeah, we're happy to have you.
Time to go back to work.
Continue the modeling. So thank you to everyone who tuned in today. We're really grateful for Dr. Chick Makel's time today. He was, an excellent speaker, and we're very appreciative of the thought he took in presenting that program. If you missed any portion of today's program, we do have it available on our YouTube channel. It'll be live just after this event is over. If you like the program today, if you like our past programs, we encourage you to donate to C2ST on our website. We encourage you to sign up for the newsletter to make sure you get the latest information on our next programs. And we hope to see you next time. Yeah, thank you for tuning in.